This is Dr. Maria Monch. She is the Director of Adolescent Medicine at Dell Children's Medical Center, as well as an Associate Professor at Dell Medical School and Texas A&M College of Medicine. She is involved in teaching and serves as the Director of Adolescent Medicine Rotation for the Pediatric Residency Program at Dell Med School. She is devoted to providing compassionate inpatient and outpatient care to the adolescents and non-surgical gynecological services. She also heads our transgender medicine clinic. She's well loved by our patients and her peers, and I'm very excited for her to speak for us today. She is going to be giving a presentation on complex menstrual management and contraception considerations for care of medically complex children and adolescents. Thank you so much, Dr. Monch.
Thank you. Thank you all for having me. I am going to pop the chat up so that I can kind of monitor it. And if you have a question as we go along, please feel free to type it in. I'm a fairly informal presenter. I'm also going to attempt to share my slides, which is always, at this point, you would think that I could do that without a problem, given how much Zoom that we do, but alas, sometimes this is easier said than done. So I am going to try that. Oh, dang. Let's see here. Going back to.
Do you have the green share screen button?
I do. And that's what I am doing, but I think it's going to share the incorrect thing.
You should be able to just go to slideshow and present your show now.
Okay. Does that look right to everybody?
Yeah, we can see it now.
Okay, thank you. All right, so I'm going to be talking about complex menstrual management and contraception, really thinking about our more medically complex children. And this is really a series of cases that are amalgamations really of what I see and what I'm asked to do. And just a way that I approach these patients, I think can be helpful. I'm really going to go into the management more than the actual mechanisms and things like that. So please, as I said, type in chat questions if you have them as we go along. Being in adolescent medicine, I have no financial disclosures. So we will review our different contraceptive options, including their indication, pros and cons of each, very briefly, high level, and then review the general approach to consideration for these medically complex patients. So I love this graphic because it pulls all of the different things into one place. This is from bedsider.org, which I have no relationship with them whatsoever, other than they have really great graphics. And I find that patients appreciate seeing everything all at once. And here are all the different available forms of contraception that we have. And we're really going to focus on the ones that are more medical management of menses versus contraception, just for the sake of contraception at this point. So really, when we're thinking about managing menses and contraception, two things come to my mind. One is, if you're using as a contraception, how effective is it? And then the second is, if you're using it to manage or suppress menses, how effective is that? And sometimes those two things don't always align. So really trying to focus in on what a patient-centered approach is what I would say. So the effectiveness of contraceptives is something that most of us know, have heard, have internalized. And a lot of it really depends on what the user has to do. So if you have something that requires a patient to come to the office, that requires to do something every day, every week, every month, that inherently is going to be less effective as contraception, and frankly, menstrual management as well. Just because it is patient and family dependent. On the other hand, if you use more of a long-acting reversible contraceptive, such as an implant or an IUD, that takes all of the doing out of the patient's hands, out of the very initial showing up for the procedure. When I talk to patients about this and they really do want birth control as the primary reason for their contraceptive or as a nice secondary benefit, I point them to the bottom of this chart where you see the implant has a failure rate of 0.05%, and having tubes tied or a tubal ligation is 0.5% failure rate. So I happily point out to those folks that if they're really trying to prevent pregnancy, that an implant is actually even more effective than surgical intervention, unless you're talking about a total hysterectomy. So this is a really great summary chart that I pulled and kind of reorganized slightly from a wonderful review article published in 2019 in JPAG, which is the Journal of Pediatric and Adolescent Gynecology, which really gives you a snapshot of the effectiveness for menstrual suppression, because a lot of times we are really looking to suppress menses and bleeding for a number of reasons. Some notable things to point out. First is if we're looking at combination oral contraceptives, or really combination hormonal contraceptives, including a patch or a ring, the dose has to be monophasic. So often folks come into clinic and they're having a really hard time with breakthrough bleeding or extended cycling, and come to find out they're on a triphasic birth control pill. And so my advice to any of my learners, anybody that I'm interfacing with, is ditch the triphasic pills. They haven't ever actually been shown in studies to be superior in any way to the monophasic pills. And if you're really looking to do extended cycling, that the monophasic pill is going to get you to where you need to be a whole lot easier than the triphasic pill. Plus, if someone misses a pill and they're calling into your office that they've missed a pill, you say, okay, which pill? They say the blue one. And then the next question is, well, which blue one? And there's like 4 different shades of blue. So really keeping it as simple as possible with the monophasic pills are the way to go. And if someone is persistent and can tolerate breakthrough bleeding, at a year, you can get almost 80% of folks to be suppressed in terms of having periods. So they really are quite effective, but I will tell you that requires pretty perfect adherence to the dosing. And it also requires tolerance of breakthrough bleeding along the way. So if you just continuously dose combination contraceptives, you will get to amenorrhea eventually, but on that route, you're going to have quite a bit of unscheduled breakthrough bleeding in all likelihood. If we move to oral progestins, I really think of that in 3 different categories. One is norethindrone category, and that is the classic progesterone-only pill that we know has about a 15% failure rate in terms of contraception. And frankly, its breakthrough bleeding rate is pretty high too. So I really move away from norethindrone itself as a menstrual suppressant. Though in some patients with absolute contraindications to estrogen and implant or other things going on, I may use it, but I would say in my practice, it's less than probably 2% of our patients that find themselves on norethindrone by itself. The medication that I do use more frequently is norethindrone acetate, which actually hasn't been studied as a contraceptive. We think it probably works as a contraceptive, but no one has done that study, and it is unlikely that anyone is going to pay for that study to be done. So that one I like a lot because I can titrate the dose. I can start people on 5 and I can go up to 10 if they start having breakthrough bleeding. I can even go up to 15. And rates with that, I find to approach 75 to 80% in terms of menstrual suppression over time. One thing to consider is with norethindrone acetate, you do get a little bit of peripheral conversion in the body to ethinyl estradiol or equivalent. So if someone has an absolute contraindication to estrogen, for example, they have catastrophic lupus with clots, it would be hard pressed unless they are already anticoagulated to really want to put them on norethindrone acetate. The risks are more theoretical than anything, but I think there's a group, most of us in the field feel like, especially if you have to get up to the 15 milligram dose, which is equivalent to about 18 micrograms of ethinyl estradiol, each 5 milligrams is about 6. micrograms of ethinyl estradiol, that we start having a little anxiety about that because we're trying to avoid estrogen for one reason or another. We can also use oral medroxyprogesterone acetate, and it's fine. I find that it has a slightly more severe side effect profile, and folks tend to not like it as much in terms of tolerability. That's a little more anecdotal than anything, but you can also titrate that one. So that one's a decent one if you're really looking for menstrual suppression. The next on there, the medroxyprogesterone acetate, the depot form of that has about a 50% amenorrhea rate at 1 year. Levonorgestrel IUDs are about 50% at 1 year, although the breakthrough bleeding tends to be with that one versus the depot medroxyprogesterone acetate tends to be more manageable, very light and spotty, sometimes cyclic and predictable. So those two methods are fairly similar in terms of their menstrual suppression rates. And then finally, you may find yourself in a situation where you're suppressing menses with a GnRH agonist. And we find that after the initial flare period, which if we're starting in someone pre-menses, let's say 10 or 3 breast development, maybe borderline 10 or 4, and you know that there's probably endometrial lining, I actually, if I'm going to put a GnRH agonist, if I'm going to pull that on board for some treatment, I may actually warn the family that there might be a first period because that flare can be pretty significant. But after that, really, there is a very good shutdown of bleeding, though obviously that comes with a lot of other risks. So that's kind of the backdrop that I'm going to use those considerations as we work through some of these cases. So my general tips and considerations in prescribing are really threefold. One is, well, first and most important is this is patient-centered. And so what I find with any medication, but of course, but even more so with birth control and menstrual management, is if the family and the patient haven't bought in, it is very hard to keep them adherent to something that you think ultimately is going to help. So I will start with, what is your goal if the patient is able to converse with me? And, sometimes it can be pregnancy prevention. And if it's pregnancy prevention, the next question is, okay, well, what's your reproductive life plan? In other words, are you planning pregnancy in the next 2 years, next year, 2 years, or are we thinking 10 years, 20 years, never? What is that? Because if someone says to me, they're 17 and they want to graduate high school, they've been in a partnered relationship or not a partnered relationship, and after they graduate high school, they're really thinking about starting a family, which honestly isn't too uncommon in Texas. They're multi-generation families kind of living together, all of which have, babies around 18 to 20 years of age. I'm probably going to shy away from something that lasts up to 7-10 years for that patient, just because that's really not what they're telling me that they want. Another thing to really keep in mind is cycle regulation. So I totally admit this, but I tend to be someone who projects my own wants of a period onto patients. In other words, I would love to not have periods. I think that sounds great. And sometimes that is not actually what the patient and their family wants. I've had to take out Nexpanons before because folks weren't getting periods and that was not acceptable to them for whatever reason. And that reason is fine. But you need to know that going in. So if the patient's goal is to have a predictable regular period every month and you put them on something that doesn't give them that, they're not going to be pleased with that method. So again, really focusing and centering the patient's needs. Patients may want to have control of their acne or improved acne. They want, maybe their goal is to have something that's weight neutral. So also patients can say, I don't want to bleed anymore, and they really want to get rid of their periods. Family goals can be often aligned with patient goals, but then sometimes slightly different as well. So one thing is hygiene. If you have a patient who's fairly care dependent, hygiene can be a big issue for families. And though it doesn't seem to be a medical indication, it can be a medical reason if that is resulting in the patient not getting great care because of the hygiene. Symptom management is another thing that the families will point out symptoms that maybe the patient doesn't recognize or the patient isn't able to communicate. The other thing that I hear not infrequently from families is, no birth control. So they want the periods managed in whatever way, but they don't want their child to be on birth control, quote unquote. And so, there may be options to do that, but again, keeping in mind what these goals are, so that as you're recommending things, you can really consider those with your recommendation. And then the third and very important thing too is, what is your goal as the provider? Is it pregnancy prevention? Again, through the reproductive justice lens, you may think that pregnancy prevention should be this person's goal, but the patient hasn't told you that, and the patient actually isn't very interested in preventing pregnancy, and they would be fine if they were pregnant. So it's really our role as the provider to, even for teenagers who we don't think perhaps in their best interest would be pregnancy in the teen years, there's the reproductive justice lens tells us that that is a patient-centered decision. We can also have goals of treating anemia, of menstrual suppression for other reasons, mood, PMDD, other things that can really be impactful to the patient that you are recognizing as the provider. A few other things to consider when you're thinking about the patient-centered approach, and one is the user or the patient. So what is their age? Are they 12? Are they 18? Are they 21? How mature are they? In other words, can they take something every day, do something every day, show up to appointments on time to get their next depot shot? What is their medical history? And does that contraindicate some of the things that you would be thinking about, but because that medical history isn't going to align with those goals, that may need to be considered too. And delivery method. I mean, I'm going to be honest that if I recommend an IUD to a 14-year-old who has never been sexually active, has never had any kind of a pelvic exam before, that's going to be really traumatizing to that 14-year-old if there's not sedation involved and other things. So you really have to consider how those things are started in order to meet the patient's needs. Also, a big thing is cost. So in Texas, our Medicaid CHIP contraceptive coverage actually does not cover contraceptives for birth control purposes. So it's only for medical indications. And so that cost then is something that a lot of families can't afford, the $1,000 for an implant or an IUD, plus the cost of insertion, et cetera. So you really do have to consider that. And then finally, access and confidentiality. So you may be in the situation where the 16-year-old or the 17-year-old says to you, yeah, I'm here because of my irregular periods, but the reality is that I want birth control. And maybe I don't want my parents to know. So can we do something that's really good birth control? And so really knowing your state's confidentiality laws is really important in terms of what you're going to do as well. So we'll move into the cases, and I have 5 cases, which I may or may not get through all 5. I tend to talk fast, so perhaps I'll get through them. And if not, or you have questions, certainly I can back up. So Sharon is a 12-year-old who's healthy. She came to your clinic because of irregular menses. Menarche was at age 11. She has gone up to 3 months between periods. And at this point, when she bleeds, it lasts for 10 to 14 days. This month, 2 periods lasting 10 days at her PCP. She was anemic with a hemoglobin of 9.2. Some initial labs show that her TSH is normal, her von Willebrand panel is normal, and her FSH is normal. So this is not an infrequent scenario, right? I would assume this likely to be some dysregulated shedding of the endometrium secondary to anovulatory cycles from an immature HPO axis, something that lands lots of kids in the hospital, in the ER, actually. And because it's in that just maybe 1.5 years since menarche, I don't initiate a big workup at that point for, is this PCOS? Is there something else that can be causing that anovulation? Really, when it's this close to menarche, I'm just trying to control the symptoms for a little bit and then hopefully transition them off and see what the underlying menstrual pattern is. That doesn't always happen, but I would say that's my general approach, because I'm not going to diagnose PCOS or androgen excess unless there are some phenotypic signs of it. In a 12-year-old that's really this close to menarche, not really meeting the threshold, for the diagnosis of PCOS yet. So in this case, the question is, what are the patient's goals, the family goals, and your goals as the provider? So you ask her and she says, I want to stay in school and not bleed. This is horrible. I'm in the 7th grade and this is embarrassing. I hate it. The family's goals are fine, do whatever, but do not put her on birth control. We don't, we can't use birth control in our family, whatever. They have some very strong beliefs there. And your goals as the provider are to correct her anemia and then prevent anemia from happening again. And also, right, to meet the patient's goals, which is to help them stay in school and socially for not bleeding. So full disclaimer, I don't pop this up in my patient's room and start going through all of this with them. I do, however, sometimes do a little modified version of this with patient goals at the top and kind of different options down the side and kind of go through each one in a table form. And you'll see this a few more times in this presentation because it's just kind of how I like to think of things, which you can go for different benefits, and then you can see how those interact with each other in terms of the different options. And so in this case, we're really, the patient's goal is amenorrhea. So we're looking down this column to see which ones are going to give us the highest likelihood of amenorrhea, with the combination hormonal contraceptives being one of the best. Another really good one can be the norethindrone acetate, like I said. We're not looking for contraception because the family is very adamant and the 12-year-old isn't who we're asking to consent for that at this point. And then, there we go. And then in terms of bone impact, so I'm always considering in a 12-year-old, like they're building bones for the rest of their lives. If I can avoid something that is going to have a detrimental effect on bones, I am certainly going to do that. So if I'm thinking maybe Depo-Provera or depomedroxyprogesterone, a 12-year-old, there needs to be a pretty compelling reason for me to go down that route. And there are compelling reasons, and we'll get to some of those. But in this case, I feel like after talking to them, the choice may be fairly clear. So if you look here are all of the options you have. Of course, I've been steering you toward what I would do. You can also do nothing. You can treat with an NSAID to reduce the amount of bleeding. NSAIDs, kind of paradoxically to what we're taught, will cause some vasoconstriction in the uterine vessels. So it actually decreases bleeding by up to 30% in some patients. So maybe you want to do that, though the amount of bleeding that she's having right now would probably not lend itself to that. And that doesn't really meet the patient's goals. So in this case, the 12-year-old with the dysregulated anovulatory shedding, we decided to start norethindrone acetate at 5 milligrams daily, titrating up if they start to have breakthrough bleeding with a maximum dose of 15. Also started iron, and then tell the family up front that, we're going to trial off of this in 6 months to a year to see if that axis has matured so that the periods from that point forward can be a little bit are more regular, and then she may not need anything at all. And if they're not, you could certainly go back to it. Of course, if you start one thing and it's not working out so well, you have a lot of movement within it. But this to me is a great first option, the norethindrone acetate. And then you tell the family this isn't contraception. Do we think it could be contraception? As I said earlier, sure, we think it could be, but it hasn't been studied as such. And so I feel very, when families say that this doesn't look like a birth control pill, it doesn't come in the traditional ring of birth control pills, it's in a prescription bottle. The next patient is a 14-year-old with trisomy 21, mild autism and hypothyroid. She comes with her mom just as a follow-up for her hypothyroid to your clinic. You get the labs that have been done and it looks like nothing is needed. But mom is, starting to notice that around period time, she's getting more irritable, and hygiene at school has really become an issue, which is not an uncommon phenomenon in some of my patients with autism. she would really like to discuss menstrual suppression, and then also the potential need for contraception and ways to manage hygiene. I will say that in a number of my patients, complex medical patients, and especially those who are very dependent on others for care, families around this age do start to worry about unintended pregnancy consequences and need for contraception. So it's certainly something to keep in mind. So again, patient goals, family goals, and your goals. So maybe the patient's goals are to manage hygiene. It may be difficult to know in this particular patient. The family really wants the hygiene piece, consider contraception, and really to look at moods. And your goals are for quality of life in the patient and also minimal medical risk. So if we again look at our chart, what that may look like, you can look at regularity of cycles and then the amenorrhea rate. You can look at contraception, the clot risk, and estrogen-containing products. Oral estrogen-containing products do have an associated clot risk. And then bone impacts. I will point you to this potential bone impacts under the combination hormonal contraceptive row. And the reason that is there have been some longitudinal studies now that do link combination oral contraceptive use in the long term to poorer bone health outcomes versus no hormones. So I am always a little bit reticent to start that if I have another option that's more bone neutral. So in this patient, this 14-year-old who's really struggling with hygiene, and also is, the family's feeling a little uneasy, maybe needing some contraception, and you want to improve the patient's quality of life, there's actually quite a few options that may work for this patient. So here's the discussion that ensued. So if we start on a combination hormonal contraceptive, though it doesn't necessarily stop bleeding at the beginning, and we said, at 1 year, it can be an amenorrhea rate of up to 80%. It does result in predictable bleeding. And predictable bleeding in some of my patients is actually quite good. The family can send the patient to school with a period underwear is a great example of something that can work really well. That, they can alert the support staff at school, et cetera, that what's happening, unlike unpredictability, which then does complicate menstrual hygiene. Ultimately, you can go to extended cycling, and sometimes I will gradually extended cycle. So I'll do just the first regular pack dosing, 3 weeks on, 1 week off. Then I try to extend it to 2 packs. Then if they make it through 6 weeks and then bleed, then the next time I may go to 3 packs and just do a gradual extended cycle. And I find that works fairly well versus extended cycling from the beginning, especially in a case when we're worried about hygiene. Again, you have to worry about clot risk and if the patient can communicate symptoms of a clot. Pills, you can do a chewable pill. If someone picks at their skin, a patch is not an awesome option. And a vaginal ring in a number of our patients who are not able to do it themselves isn't really a great option. An implant or an IUD would require sedation in this patient. The bleeding profile could be fairly unpredictable, especially at the beginning. It does provide contraception. The duration, especially in a levonorgestrel IUD, up to 7 years is quite appealing. And potentially, if this patient was going to be sedated for something else, it's certainly something that you can consider looking into. Depot injections for this patient, they didn't like needles. There was no chance that we were going to be able to go down that route. Also, the unpredictable bleeding wasn't too appealing to the family. The norethindrone acetate, like we just discussed in the last case, is possible for menstrual suppression. There is breakthrough bleeding potentially associated, but because of the lack of contraceptive benefit, the family decided that wasn't a great option for them. So ultimately, we did the first thing, which was a chewable combination hormonal contraceptive, regular pack doses, and then we did extended cycling. Her moods actually got significantly better. The hygiene was better, and the family feels pretty good. That was a win in our clinic. That one, it's not always quite so easy and straightforward, but that's kind of the pros and cons of those in that patient. This is a 13-year-old with a history of precocious puberty who had a GnRH explant 2 years prior, and now has had menarche within the past 6 months. She has refractory epilepsy, which is always a challenge. And currently she's on prescription strength CBD as well as lamotrigine. Anytime you see lamotrigine, your ears should perk up as like, oh, this could be complicated, because it is a little bit. So the family and the neurologist are starting to notice that seizures are clustering in the couple of days prior to menses. She is ambulatory. She doesn't really mind her periods that much. She's actually worried about acne. Her BMI is normal. So the patient really wants to have fewer seizures because the seizures are impacting her life. She wants her acne to get better. The family really wants her to have fewer seizures because some of these have gotten pretty bad. And you are really trying to minimize medication interactions given the seizure regimen that she's on right now and improve her quality of life. So unfortunately, or fortunately, just the way it goes, combination hormonal contraceptives are really the only one that have acne benefits, especially if one of the acne components is the hormonal part. If it's not the hormonal part, it's not going to be very helpful with acne. But it really, of all of them, is the only one. As a matter of fact, some of the other ones could make the acne worse. Medication interactions are most likely with a combination method. So those are the things that we have to consider for this patient. So just a word on catamenial epilepsy or menstrual epilepsy. Over a third of patients who have medication refractory epilepsy will have seizure exacerbation with their menses. Lots of medications are often in play in these patients, so that potential for medication interactions really does go up when you're adding hormones into the mix. Interestingly, progesterone has been shown to have anti-epileptic properties, whereas estrogen has been shown to have proconvulsant properties. Depo-hydroxyprogesterone acetate has been studied in catamenial epilepsy to reduce seizure frequency. So it, in and of itself, can add and be helpful in these patients. A note about lamotrigine is that combination hormonal contraceptives will actually decrease lamotrigine levels and can increase seizure risk. And then a lot of the AED medications will actually speed up the metabolism of the contraceptives, so it can increase contraceptive failure. So those patients really need to have backup contraception. And here are some examples of meds that do speed up the metabolism of hormones. So in this patient, we decided to do a trial of depo-hydroxyprogesterone acetate, given the potential impact on the seizures. CBD isn't really well studied. We don't know what happens with it with any of these medications. We discussed that her acne could actually, unfortunately, get worse, but the seizures we've decided were more important. And we talked about some other acne regimens. We plan to reassess at 6 to 12 months and then consider a DEXA at 12 months, just given her AED use over the years. And frankly, there comes a point when you're really weighing with risk and benefits. If the patient is getting a lot of benefit from being on depo-hydroxyprogesterone acetate and they are not seizing as much, that may be worth the bone health trade-off. But it's a patient-dependent discussion that has to be had. And there's some other kind of things along the way that can impact that as well. But it can be pretty striking, the difference in those. I will summarize this patient to say that it's a 10-year-old who has spastic CP, is wheelchair-bound, total care on a ventilator. She has autonomic storming, and it's worse in the days prior to her periods. So really, we're looking at quality of life, reducing autonomic storming, and potential risks of that and benefits. In a patient who is non-ambulatory, we're really trying not to use Depo-Provera, though sometimes we need to. And in this case, we think that the storming may actually be related to a drop in progesterone levels late in the luteal phase, which is not uncommon, also a typical seizure trigger time. So these cases require a lot of input from a lot of folks. It was decided that a combination method, due to the ambulatory status of the patient, which would be non-ambulatory, there was potential increased clot risk, though that's a more theoretical risk in this population. The bone health risk was also something to really consider. So ultimately, we decided on an implant that can last up to 5 years. And it was done during a sedated procedure for something else and actually went fairly well. Hygiene wasn't a big issue. So sometimes we say, oh, there's a lot of breakthrough bleeding, but the family doesn't really care about hygiene for a lot of these. It's really trying to knock down that cycling of the hormones. And then the last case is an 18-year-old who had premature ovarian insufficiency, who had been on replacement with transdermal estrogen and cyclic progesterone for 3 years. And now she really wants birth control, knowing that though the chance of fertility is quite low, it is still 5 to 10% at last data that I saw. So she really feels like she needs birth control and doesn't think that she can remember to take pills every day. Most of my patients going off to college have a hard time, remembering to do anything every day, let alone take a pill to prevent pregnancy. So you're really worried about the bone health impacts because that's one of our biggest things in POI aside from the fertility. And so ultimately, we made some decisions, but the Depo-Provera is again less ideal. You can certainly transition to a combination method, and there's evidence for doing that. I like that better as people get older and have really laid down most of their bones. So I'm really trying to think of bone neutral things for these patients. And so implants and IUDs are really, I'm trying to steer them toward that. And in this patient, ultimately, we decided on continuing her transdermal estrogen and actually putting an implant in for the birth control. And then she didn't have to cycle with the progesterone because she was getting endometrial protection with the implant. And that worked well for her. I've done that in a few cases. Just a reminder, if you're curious about any kind of medical contraindications to the methods that you're looking, I direct you to the CDC. There's an app, which is lovely. The new guidelines should be coming out in the next year, I think it is. So that's just a great resource. And so finally, that was lots of talking, but the really patient and family-centered decision-making is, as I said, likely to improve adherence and buy-in. And if you can really center those needs, I think you're going to go a long way. If you're able to recognize the advantages and limitations and leverage those to meet the family's needs, again, it's you're going to have a lot of success. So there was a question about the variable weight gain effects of the different medical options and how if someone comes in a bigger body, what do we do at that point? Honestly, sometimes it depends on the patient's goals. Birth control pills get a bad rap. But in most of our studies are actually weight neutral. So what I say for families is, they're weight neutral, which means that some people gain, some people lose, but on average, everybody stays the same. The people who lose don't write about it on the web. The people who gain write about it. So you're kind of getting a skewed data. I try to avoid Depo-Provera, frankly, in my patients who are in bigger bodies. But at the end of the day, the thing that will cause their weight to go up even more is pregnancy. So if the way that they think that if they're not ready for pregnancy, they are sexually active, they aren't interested in a lark, or their insurance doesn't cover it, which is also something that happens, we may go with Depo, recognizing that the risk of weight gain with Depo is higher in those patients who are already starting at a higher weight. So sometimes we radically accept that is going to happen. And at the same time, we're also talking about, their moods and their movements and kind of how they're feeding their bodies and things. So we're really trying to hit it from all angles. But sometimes the patient goals, you got to go with it, because if you put them on birth control pills because you're worried about weight gain, or you recommend an IUD, they may not come back, they may not adhere to it. And then the next thing you know, they're pregnant, which was not one of their goals. So it is complicated. I would say that just having a frank discussion, and some of our patients are willing to accept that because the risk of pregnancy for them is a lot greater than actually the risk of weight gain with something like Depo. But though once the weight has come on with Depo, it is very difficult to get it off. So it is certainly present. and just, I think, an informed discussion. So I will thank some of my colleagues who gave me some framework for this. I told them that I would acknowledge them because they gave me a couple of the photos. I'm always happy to answer questions. Here's my email address. Please feel free to email me at any point.